Good morning, everyone. So before I start, I just want to, lay your attention towards this slide. So we're looking at node positive non-metastatic bladder cancers. So how good they do? So they have a median overall survival of just 1.55 years and a median progression-free survival of just 0.95 years, irrespective of the type of treatment you do. Whether you do a radical cystectomy, you do radical radiotherapy, you do palliative treatment, you do chemotherapy. So median overall survival remains 1.55 years and progression-free survival is just 0.95 years. So let me begin. 50% of urinary bladder cancers recur after surgery, while 10 to 15% patients are metastatic at presentation itself. The role of radiotherapy has expanded in treatment of bladder cancer, particularly in muscle-invasive node-negative bladder cancers. But recent evidences suggest bladder-sparing treatments as viable alternative modality, even in node-positive patients. According to international guidelines, bladder-sparing trimodal therapy is an alternative to radical cystectomy, as was presented a couple of presentations before by my colleague as well. So what are the principles of bladder-sparing approach? All bladder-sparing approaches are based on the principle that not all cases require an immediate cystectomy. So first, the patient has to be given an option of a radical bladder-saving approach. And traditional bladder-preserving approaches are reasonable alternatives to cystectomy for patients who are medically unfit for surgery and those seeking an alternative to radical cystectomy. So I'll just quickly, tell you about these two studies. One which is published in World Journal of Urology. It's a meta-analysis of 73 studies, incidence and outcome of salvage cystectomy after bladder-sparing therapy for muscle-invasive bladder cancers, which comprises 9,110 patients. They reported only 19.2% of patients with bladder-preserving therapy require a radical cystectomy later on. And another study published in NEJM, which is the phase 3 randomized control trial, in which we see that patients receiving chemoradiotherapy, only 14% of them received a cystectomy after 5 years. And patients who received just radiotherapy had 22% of cystectomies at 5 years. So although radical cystectomy was historically perceived as a sole gold standard radical treatment for bladder cancers, there's no increasing recognition within international guidelines that bladder preservation is a valid alternative option. However, this population is underrepresented in advanced bladder trials. NCCN guidelines for bladder cancers for node N1, N2, and N3 disease, chemoradiation is a category 1 option for patients. So this is the NCCN guidelines 2024, where we can see that concurrent chemoradiotherapy is a category 1 option for stage 3A and stage 3B bladder cancers. So coming to my topic, which is bladder-sparing treatment with radical dose radiotherapy. So this is a UK multi-center retrospective analysis of survival outcomes in node-positive patients. So a total of 287 patients received the treatment. Radical treatment was received by 163 patients and palliative treatment by 124 patients. So radical treatments, among radical treatments, patients received either radical cystectomy or radical radiotherapy. And for palliative patients, they received either systemic anti-cancer therapy or palliative radiotherapy, or a combination of both, or best supportive care. So these are the results. So if we see if there's any difference between the palliative treatment and radical treatment, yes, there's a difference in overall survival and progression-free survival. So what should we offer to these patients, palliative treatment or radical treatment? The answer is radical treatment. Now, the next question is, among the radical treatment, should we go for a radical cystectomy or a radical radiotherapy? So these are the results. We see that overall survival and progression-free survival in both the groups is comparable. So whether we are doing a radical cystectomy or a radical radiotherapy, the results are the same. And even if you add chemotherapy, either to radical cystectomy group or to the radical radiotherapy group, again, the overall survival and progression-free survival is the same. For patients who are undergoing just radical radiotherapy, adding a radiosensitizer does not, again, affect the overall survival and progression-free survival. It's again the same. And one interesting point is that, when we are giving radiotherapy to these patients, if we treat bladder only, and we treat bladder along with the nodal basins, again the results are the same. So additional increasing the radiation portals does not have any benefit in overall survival on progression-free survival. So I've tried to summarize the results in a single chart. So these are a total of 287 patients. I told you median overall survival 1.55 years and the progression-free survival 0.95 years only. Radical treatment was received by 160 patients, palliative treatment by 124 patients. Median overall survival definitely better in the radical treatment group. And again, 2-year overall survival, again better in the radical treatment group. And among the two radical groups, radical radiotherapy and radical cystectomy, median overall survival and 2-year overall survival, although slightly better in the radical therapy group, but they are comparable. So what is the takeaway from this study? Patient cohorts with node-positive, non-metastatic bladder cancers had equivalent survival outcomes whether treated with surgery or radical radiotherapy. And given the known morbidities of radial cystectomy in a patient group with poor survival, this study confirms that bladder-sparing trimodal therapy treatment should be a treatment option available to all the patients with node-positive, non-metastatic bladder cancers. So before I say thank you, just an ongoing study comparing concurrent chemoradiation with immunotherapy. This is an INSPIRE, which is the first prospective study designed for such cohort of patients, which will define both short-term and long-term outcomes for bladder sparing in this patient population and has the potential to define a new treatment strategy. There they have added an immunotherapy durvalumab. So we really don't know, maybe in future, in spite of the trimodal therapy, we may have a quadruple therapy, including trimodal as well as the immunotherapy. Thank you so much. Thank you.